Hello everyone, welcome. Today we are going to talk about cerebral edema in pediatric practice. Let's start. Cerebral edema is basically accumulation of fluid in the intracellular or extracellular spaces in the brain tissue. Your brain is composed of billions of neurons, and they have got the supporting glial cells as well. And then the whole brain is enclosed in the membranes, which are of three types: the dura mater, the arachnoid, and the pia mater, and it's got fluid inside it, which is known as a CSF fluid. So this CSF fluid acts like a cushion, and the whole thing is enclosed in the skull. So please keep it in mind that once the suture are fused in kids, there is very little space for the brain to swell up. So in case if anything increases, whether it's a brain tissue, whether it's the blood component, or it's a CSF component, so it's going to increase the pressure inside the skull. So keep it in mind that due to any reason, if there is an increase in the fluid content, whether it is inside the cells, neuronal cells, or whether it's outside the neurons, that is in the interstitial spaces, that by definition is cerebral edema. Now, many people confuse cerebral edema with increased intracranial pressure, though one can lead to the other one. So cerebral edema can lead to increased intracranial pressure, but keep it in mind that increased intracranial pressure is a different thing. Increased intracranial pressure simply means that the pressure inside the skull increases. And it could be because of increase in the CSF component, it could be increase in the cerebral blood flow, or it could be increase in the brain tissue itself. So any increase in one of these three things is going to put a pressure inside, and the pressure would increase because the skull has there's very little movement inside the skull cavity. It's closed from outside. Obviously neonates are an exception because they've got open suture, and to some extent the head can grow to accommodate the pressures. But in older children, once the suture are fused, then obviously it's going to increase the pressure inside the skull. So that is increased intracranial pressure. So keep it in mind. For technical definition, any pressure which is greater than 28 millimeter of mercury, that would be classified as increased intracranial pressure. So keep it in mind, cerebral edema is basically the accumulation of fluid in the intracellular or extracellular compartment, while the increase in pressure is increased intracranial pressure. And keep it in mind that cerebral edema can lead to increased intracranial pressure. They are related with one another. Now, cerebral edema itself is not a separate clinical entity. It's considered to be a manifestation of different pathological processes going on in the brain. So a child can get cerebral edema if he has got a traumatic brain injury. He can get cerebral edema if there is any process which leads to infarction. He can get cerebral edema if he has got a tumor. He can get cerebral edema if he suffers an insult, a hypoxic ischemic insult to the brain. So there are different types of pathological processes which ultimately would manifest in the form of cerebral edema. So cerebral edema basically is a manifestation. It's a sequelae of various pathological processes. So moving ahead, talking about the different types and causes of cerebral edema, and you should understand this thing. Now, different books have classified it in different ways. Some say there are 4 types, but primarily there are 3 basic types of cerebral edema: the cytotoxic variety, the vasogenic variety, and the interstitial variety. Now, the cytotoxic variety, cytotoxics mean that obviously, as the name says, toxicity to the cells. In other words, insult to the cell, injury to the cell, and this is caused by anything that that directly damages the neuron. So what happened? It could be traumatic brain injury. It could be an hypoxic ischemic encephalopathy or hypoxic ischemic insult in the early part of life. It could be diffuse axonal injury, again caused by blunt trauma to the brain. So what happens in whatever is the reason, the neurons, their cell membrane permeability increases. So the permeability, how it increases, there is what happens that there is a problem with the calcium and the sodium pump. So they just open up. When they open up, what happens that the sodium moves inside. So when the sodium moves inside, it draws water with it. So what happens as the sodium goes inside, there is a lot of water being drawn inside the neuron. So the neurons, they swell up. The neurons they are full of water. So that leads to injury. So in the initial phase, it would be reversible injury, but once there is the fluid inside the cells for a considerable period of time, then it can lead to irreversible injury and the cell would die. It would lead to necrosis. So on the cell membrane of the neurons because of various reasons, mostly traumatic brain injury or any other form of insult. Now, vasogenic type of cerebral edema. Now, this is caused by increased permeability of the capillaries. We know that the brain has got the blood-brain barrier. So the capillaries have got very tight junctions in between. Not everything can simply leak out of the capillaries. But because of various reasons, usually it could be tumors, it could be infections, it could be abscesses, it could be stroke, whatever is the reason. So what happens is that the permeability of the capillaries, because the endothelial lining, the junctions between the endothelial lines, they break down. So what happens? The fluid component of the blood leaks in. It goes in the interstitial spaces and it accumulates in that and causes cerebral edema. While the third type, which is known as the interstitial cerebral edema, that is simply caused by obstruction to the outflow of CSF. So if the CSF outflow is blocked for any reason, whether these are adhesions or anything, so what would happen? The CSF would not be able to go out of the brain spaces. It would accumulate inside. As the pressure builds up, it would simply leak in the interstitial spaces between the cells of the brain. Now also keep it in mind that cytotoxic cerebral edema, it primarily affects the gray matter and to some extent the white matter as well. But keep it in mind, primarily the gray matter would be affected, and it's very important because while once you let's say you are suspecting cerebral edema and you do the CT scan, then depending where you find the cerebral edema, like for example if it is extending to the gray matter, then it gives you an idea that it's most probably cytotoxic cerebral edema. And if it's not extending to the gray matter, then you know that it's most probably the vasogenic cerebral edema. So here keep it in mind that cytotoxic cerebral edema predominantly, keep it in mind, predominantly affects the gray matter. Though white matter is not an exception, to some extent it can also involve the white matter, but predominantly it would involve the gray matter. Vasogenic cerebral edema, on the other hand, primarily involves the white matter. It does not extend into the gray matter. Why? Because it is not cytotoxic. It's not going inside the cell. So obviously the cells are there in the gray matter, while the white matters are the axonal parts or the glial part. So the vasogenic cerebral edema is actually confined to the white matter, and interstitial cerebral edema is also confined to the white matter. So keep these three things in your mind whenever you are reading a scan. Now moving ahead, how do we diagnose? I told you it's basically a sequelae or a complication of different pathological process. So based on the history or based on the symptomatology, you can get an idea if somebody had a traumatic brain injury or somebody had a fever with neck rigidity, seizures, or somebody, let's say a child was born and he didn't cry for the, let's say 10-15 minutes, and during that time he suffered hypoxic ischemic encephalopathy. So the history would be, would be giving you an idea what has happened. But apart from that, there are signs and symptoms. Again, these are non-specific signs and symptoms, but that gives you an idea whether cerebral edema could be one of the manifestations of the underlying pathological process. So the first thing that we have seen, like the most common thing and the most early symptom that we see in cerebral edema is headache. Now, headaches are very non-specific. You get headache because of tension headaches. You get some headaches because of refractive errors. You can get headaches because of problems anywhere in the head and neck region. You can get headaches because of migraine as well. But keep in mind, if there is something going on recently, there is sort of a traumatic brain injury or there has been some evidence of meningitis. So remember that in the backdrop of these things, a headache might be an early symptom that cerebral edema is developing. Visual problems is another thing, because as the pressure increases, puts pressure on the optic nerve, and usually children who have got cerebral edema would complain of some problems with their vision, and it's usually the peripheral vision that is involved. So central vision is still preserved. The peripheral vision is usually involved in the early stages. In the late stages, they might have gaze problem. So vertical gaze problem, where they are mostly looking downward, and upward looking causes diplopia because of the cranial nerve involvement. That could also be an issue. Vomiting, especially early morning vomiting, is very much suggestive of increase in intracranial pressure or cerebral edema. What happens basically, because when a child is lying throughout the night, the fluid accumulates because of the position inside the brain. There is more like edema, and it presses on the posterior part of the brain. And as soon as the child wakes up in the morning, that pressure actually manifests in the form of vomiting. Altered mental status is another thing. Obviously, low GCS after a brain injury, or after an infective process, or after, let's say, a child who suffers stroke from one reason or the other. Altered mental status is another symptom that can point towards the cerebral edema. Remember, in small children, altered mental status, speaking of altered mental status, is very difficult. Most of them, they would present with irritability. Seizures is another thing, like, if there's a lot of pressure, kids can have seizures, different type of seizures. And late in, like if the intracranial pressure increases, it can lead to symptoms associated with brainstem herniation, or like other parts of herniation. It could be supratentorial herniation or infratentorial herniation. And again, the different types of herniation have their own associated symptomatology. Fine. The other thing which helps you in diagnosis is doing a fundoscopy. So if you're looking at the fundi, you look at the optic disc. So if the optic disc margins are blurred, normally optic disc margins are very sharp, so you can like demarcate the optic disc margins from the rest of the retina. But if you see blurring, if you see that you cannot actually make where the fundi they end, that is usually a manifestation of increased intracranial pressure secondary to cerebral edema, and obviously that means then the process is going on. Optic nerve ultrasound is another thing. Like you can look at the optic nerve sheath diameters, and if there is swelling, that diameters increases. So in expert hands, optical ultrasound can also give you an indication whether there are any chance of cerebral edema or not. The most common non-invasive modality that is used to diagnose cerebral edema and its subsequently increased intracranial pressure is CT scan, and we will talk about that in a moment. And in settings of intensive care, invasive intracranial pressure monitoring, where they put a probe inside the brain which monitors the pressures, that is another thing. Again, there are two schools of thought. Some say it should be done, some are not in favor of these things, but nevertheless it's an intensive care setting, so I will not go into details of that. So these were a few of the things that help you in diagnosing cerebral edema, and as a consequence increased intracranial pressure. Now moving ahead, talking about the CT scan finding, and this is something that I want you to focus on, because as a doctor you will come across where you have to read the CT scans, and you should be able to differentiate between vasogenic cerebral edema and between cytotoxic cerebral edema. So let's go one by one through them. So we'll start with this diagram A, or the figure A. Now here in figure A, if you see, this is a CT scan. And in the CT scan, if you compare both sides, here you can see that there are hypodensities which are there in the white matter, and it has got finger-like projections. See, these are finger-like projections. Finger-like projections which are not reaching the periphery. The periphery is mostly the gray matter. So it's not reaching the gray matter, and it's got finger-like projection. So remember, whenever you see hypodensities with finger-like projection, obviously it could be infarction, but remember, not everything is infarction. Finger-like projections with hypodensities not extending to the periphery of the brain, this is very much suggestive of vasogenic cerebral edema. So this is vasogenic cerebral edema in the right hemisphere. Now compare it with the figure B. In figure B, if you see, there is a wedge-shaped hypodensity which is actually extending to the periphery of the brain. So remember, if it is not finger shape but rather it is wedge shape and it is extending to the periphery. Of the periphery means that it's involving the gray matter, and to some extent it's also involved the white matter. So whenever there is a wedge-shaped hypodensity which is extending to the periphery of the brain, in other words involving the gray matter, that is cytotoxic brain edema. So this one is a very classical example of cytotoxic brain edema. And if you know what causes vasogenic cerebral edema and what causes cytotoxic brain edema, then obviously you can further narrow down your differentials. Now focus on the figure C. Again, figure C, you can see that in the frontal lobe, there are finger-like projections, and they are primarily involving the white matter, though some of them have reached the periphery as well. So this is predominantly vasogenic edema. But obviously, there might be a little bit of cytotoxic component. Well, predominantly, this is vasogenic edema. Why? Because it is involving the white matter and it is finger-like hypodense lesions on a CT scan. So this is primarily vasogenic edema. Here, the two you can see side by side, the cytotoxic brain edema and the vasogenic brain edema. Again, if you look here in the right lobe, you can see almost roughly, if it is not wedge shaped, you can say it's a box shape. Again, it's not necessarily that everything would be wedge shaped. You can have any combination of that. It's roughly a box shape. But again, see, this one is a hypodensity which is extending to the periphery, to the gray area. So if it is extending to the gray area and it's also involving the white area, so that is cytotoxic edema. And I told you cytotoxic edema can be caused by traumatic brain injury, hypoxic ischemic encephalopathy, infarction, etc., etc. Then again, compare it with the other one over here. And here you have got again hypodensities with finger-like projections. And again, if it is a hypodense lesion with finger-like projections, it is vasogenic. And vasogenic edema is mostly caused by, there are different reasons, but most commonly it will be caused by a brain tumor. So whenever you have got like somebody who has got a very non-specific history, headaches, you do a CT scan and you find vasogenic edema, just look, you might see a tumor somewhere in the vicinity. So this is vasogenic edema. So the CT scan, so it's very simple. When you are reading the CT scan, look for hypodense lesion. So hypodense lesions which are finger-like in shape and not extending to the gray matter, they are vasogenic cerebral edema. And if it is wedge shape or box shape and it is extending to the gray matter, that is the periphery of the brain, then it is cytotoxic brain edema. So I hope you keep these things in mind and it becomes very easy. I mean, you can become an expert in reading CT scan and diagnosing which type of brain edema it is. Also look for other features on the CT scan. Sometimes because of the brain edema, you might see a midline shift. If midline shift is there, it becomes a neurosurgical emergency because some form of decompression has to be done immediately. It could be medical decompression or it could be surgical decompression, whatever. That is the domain of the neurosurgeons to take it from there onwards. But nevertheless, you look for, if you find other pathological processes, you might see something which is looking like an abscess. So you might find something which looks like a tumor. But anyhow, nevertheless, the focus here at the moment is how to differentiate between cytotoxic and vasogenic edema. So having said that, let's move on and talk about the management. Now, the management of brain edema, cerebral edema, again, the principle is very simple. Manage the underlying cause. You know, cerebral edema is a manifestation of some pathological process. So it could be caused by tumor. If it's caused by tumor, you have to remove the tumor or treat it. If it's caused by, let's say, an abscess, you have to remove the abscess. If it's caused by traumatic brain injury, then you have to give rest to the brain till, it recovers to some extent. So managing the underlying cause is the main principle. With that comes three domains: the nursing management, the medical management, and the surgical management. The nursing management is primarily the domain of the nurses. So these patients, whether they are in the medical unit, whether they're in the pediatric unit, whether they're in intensive care, they should be kept in head up 30-degree. Obviously, you can't keep the head down because then, because of gravity, all the blood flow would go towards the brain, and it would aggravate the condition of brain edema and lead to further increase in intracranial pressure. So you need to keep the head up. 30 degree is the recommended angle, but they should be kept. They should also be sedated, so they are not coughing, they are not straining, because straining, coughing, all these things lead to increase in intracranial pressure, and that can further aggravate the condition. So they should be kept in sedation, and obviously you have to make sure that they're not coughing and not straining them. Again, this is the domain of the nurses. Coming down to the medical management. So medical management, most of the time we manage them conservatively, and that means medical management. Again, three types of treatment modalities are used. Number one, the key medication that we use is steroids. Then we can have the hyperosmolar agents, and then there are specialized things which are used in the intensive care setting. So let's talk about steroids. Steroids, especially dexamethasone. Steroids are beneficial only in tumors and to some extent in meningitis infections. So if the vasogenic edema, remember tumors causes a lot of vasogenic edema in the surrounding of the space occupying lesion, and that leads to headache, that leads to pressure effects and other things. So steroids are very helpful because it helps in reducing the vasogenic edema. Dexamethasone is the drug of choice to use if the vasogenic edema is caused by tumors, or sometime with infection like meningitis as well, where obviously you have to give antibiotic cover as well, but you will be adding dexamethasone as well. Now coming down to hyperosmolar agents. Hyperosmolar agents can be used in a variety of settings, mostly in traumatic brain injury. We also use it in cerebral edema secondary to diabetic ketoacidosis. Remember, cerebral edema due to diabetic ketoacidosis is one of the most dreaded complications of type 1 diabetes. Here in UK, I think annually 9-10 people, the kids they die because of cerebral edema every year. That's not a big figure, but nevertheless, it still pins the importance of identifying and managing this condition. And usually it is treated by hyperosmolar agents. So the one that we prefer is 3% saline. So 3% saline can be given in the form of continuous infusion, and the dose is usually around 0.1 to 1 mils of 3% saline per kilogram per hour in the form of a continuous infusion. So as long as it is required, you can give 3% saline in the form of 0.1 to 1 mils per kg per hour. Or we can use the 20% mannitol, which is an osmotically active agent. So what happens, whether it is 3% saline or 20% mannitol, they are osmotically active agents. What they do is they would draw water from the brain interstitial tissues and back into the blood. So they are actually like a magnet. They draw the fluid out of the brain. 20% mannitol can be given in a dose of 0.25 to 1 gram per kg, and it's usually given intravenously over 20 minutes. Again, it can be repeated as and when needed. It's also important that when we are giving hyperosmolar agents, we have to keep an eye on serum osmolality. And please make it in mind, the Nelson 21st edition says that the serum osmolality should be kept under the radar screen and should never be allowed to go above 320 milliosmol per liter. So keep this figure in your mind. Then the intensive care management, again, these are very specialized things. Some of those who have got increase in intracranial pressure, they are obtunded, the GCS is very low, they've got other pathological processes going on as well, so they are put on controlled hyperventilation, so they are intubated, the carbon dioxide is blown off, and that leads to vasoconstriction, and that vasoconstriction helps in reducing the cerebral edema. They can also be put on hypothermia, so between 32 and 33 degree centigrade temperatures are on, that it decreases the metabolic rate of the neurons, and that also helps in reducing the edema. Or sometimes the pentobarbital, which is a barbiturate, that can also be given in the form of infusion, because that research has shown that it also decreases the cerebral metabolic rate and helps in reducing the cerebral edema. And then where there are surgical reasons like a space occupying lesion in the form of an abscess or a tumor, then it has to be surgically removed. If there is a hydrocephalus and the pathology is not known, the surgeons can put up a VP shunt, ventricular peritoneal shunt. And sometimes where there are conditions like idiopathic intracranial hypertension, which is a disease of the adolescent girls, usually presents with headaches and visual problems. Obviously, CSF can be trained to decrease the intracranial pressure. So this is the management of cerebral edema, and it is divided into nursing management, the medical management, and the surgical management. Remember, in medical management, the important thing that you should understand, the cornerstone, especially in vasogenic edema caused by tumors, is dexamethasone. And for other reasons like infarction, stroke, cerebral edema due to diabetic ketoacidosis, we use hyperosmolar agents like 3% saline or 20% mannitol. And there are some specialized modality which are used in the intensive care settings. There's no need of going into the detail. You should just know which are those. Like one is controlled hypothermia and controlled hyperventilation as well. So I hope you have understood the basics of cerebral edema, its diagnosis and its management. So if you have liked this lecture, do give me a thumb up, and if you haven't subscribed so far, do subscribe to my channel. Share my videos with your friends, and if you've got any question, you can put it down in the comment section below and I'll get back to you and answer those questions. Thank you very much. Have a good day. Stay safe. Bye bye.